Nurse Theorists, Portraits of Excellence. In this edition, we feature Dr. Margaret Newman.
My grandparents on my father's side lived in Marion, Arkansas, just across the river from Memphis. And my grandfather died when I was about 3, so I didn't know him too well, but he was kind of a wheeler dealer. I don't really think of my grandmother as Southern. She was such an individual and very independent, and she was a Christian Scientist. And she was very influential with her sons, including my father. So she was a very dominant, intellectual type lady. When I was born, my mother and father had just completed the construction of a tourist home. This was 1933. And they had decided that with the automobile, people were going to be traveling a lot, and tourist home would be a good investment. But it was also the depths of the Depression. And so there weren't very many tourists. But my mother was the manager type. She managed the tourist home. She was very outgoing. She could size up someone coming to the door immediately and know whether or not we had any rooms available, depending on her analysis. My father was more an introvert, and he would go back to his room to read his Science and Health, Mary Baker Eddy's Christian Science book, when anybody would come. He was the contemplative, introspective type. I had good times with both of them when I was a child because my mother was always fun and outgoing and went places, but my father and I would spend rainy, stormy afternoons on the front porch doing what he called rapid calculations, different kinds of mathematical calculations. He loved math, and I did too. So those were the fun times with him. I was born in Memphis. My childhood was definitely a Southern girl's childhood. I can remember when I would meet little boys to play with, my mother would tell me, now don't let them know you're smart. Don't ever disagree with them. Make sure that you flatter them, that kind of thing. And so for a long time I had to try to kind of squelch my own personality to be the flattering Southern lady. My mother really wanted me to have all of the social skills. I started taking dancing lessons at the age of 4. I was taking piano lessons also. But I loved dancing, and my secret ambition, or it wasn't really so secret, was to be kind of like a chorus line girl, you know, in Rockettes in New York or something of that sort. I always loved school. I was on the honor roll and was kind of known as A+ Ann. Isn't that a terrible word? It got to be kind of a burden because every class period then I had to have all A's. You know, I couldn't ruin my record. The principal of the grammar school I went to used to talk about arithmetic as just one beautiful puzzle. And that's kind of the way I felt about arithmetic, particularly with my father's interest in math also. She said, you ought to regard a test as your opportunity to really show what you know. And so tests always, for me, were more that kind of an experience rather than being evaluated. The high school where I went was very socially active, had a lot of sororities and fraternities. That was actually my main social outlet during high school. And by the time I was a senior, I was president of the sorority. I really loved that kind of activity. I went to Baylor after I graduated from high school, and I wanted to go to a large enough university that it would have all of the aspects of a university as well as the religious climate. I wasn't sure what I wanted to do. My father died when I was in high school, and during the time that I was at Baylor, my mother was gradually becoming ill. She had some symptoms when I was in high school, but they weren't incapacitating. But during that period of time when I was at Baylor, bit by bit she became more incapacitated. She had ALS, Lou Gehrig's disease. It's a degenerative neurological disease. So by the time I graduated from Baylor, she was very dependent. In searching for some sort of career commitment at Baylor, I began to think a little bit about nursing, but I really did not want to go into nursing. It represented all the things I did not like. Interestingly enough, my roommate, my junior year, was a nursing student. And she was just a beginning nursing student. She had changed from a music major, by the way, into nursing. And when she got her first uniform and her first little white shoes, I thought, oh, how horrible. But we had a tornado in Waco that year, and we were all sitting around doing nothing, and they came in and called her out to go help at the hospital, give injections. And I thought to myself, she has a purpose and I don't. So that was kind of the beginning of my really thinking very seriously about nursing. This lingering call to nursing was really a burden, and I kept praying for direction. With my mother being ill, I couldn't just quit my job and go back to school. I prayed that if the Lord really wanted me to go into nursing, that He had to open up the way before the fall quarter. This was now in 1959. And one morning, as I had just finished this prayer, I went into my mother's room and she had died. And it was the answer to my prayer. I had 2 weeks to get into the nursing program at the University of Tennessee. As soon as I got into class and began to study the complexity of the human being and the illness and so forth, I knew that it was for me. It was very exciting from the very beginning. I had a class of 27 other women who were entering nursing. It wasn't like college freshmen because they had already been through a year or two of college before coming into nursing at the medical center. And they were a very intelligent, sensitive, committed group of women. And I thought to myself, if I just wanted to go out and choose 27 friends, I couldn't have done a better job. As soon as I graduated, I stayed around for a year as a clinical instructor in the medical surgical area. But I was in the process, even then, of seeking a graduate program. I looked at the faculty in nursing at both of the programs, UCSF and UCLA, and was particularly impressed with Helen Naum, who was the dean at UCSF at that time. And also I was attracted to the beautiful city of San Francisco, and so I decided to go there. And that was just a wonderful learning experience for me. My first publication came out of a study I did that year. It was hard to leave California when I graduated because this was just a 2-semester program, and so I wasn't there but 9 months, and I really wasn't ready to leave. But I had been offered a position back at the University of Tennessee in Memphis, and my fiance at the time was from Tennessee, so it was logical to go back to Tennessee for a period of time. And I joined the faculty at the College of Nursing, teaching in medical surgical nursing. But at the same time, they were opening a new clinical research center at Tennessee, and the clinical director, a physician, had been a good friend of mine and asked me to be the director of nursing for that clinical research center. I went back to the University of Tennessee in the summer of '64, and then I left there in the summer of '67 to pursue graduate study again. So I was there about 3 years. I went to NYU for my doctorate. I wanted to get a PhD. I had read practically everything Martha Rogers had written, and it was almost as though she had written it for me. There was so much congruence between what she was saying and what I thought we needed to do in terms of development of nursing knowledge. I had been interested in the problems of restriction of movement and what it means in terms of one's space and time in my experience with my mother, who was totally paralyzed, and what that did in terms of my own space and time as well, being responsible for her care. So I got into rehab at NYU, which was a more long-term kind of focus. I was at NYU 6 years. I think after a while the concrete got to me. I needed to be able to put my feet down on grass, and I needed more of a grassroots approach in terms of nursing as well, because I had been teaching theory development to doctoral students, and in a sense I was kind of in my ivory tower, and I wanted to get closer to what was going on at a grassroots level in terms of practice. So I decided to go to Penn State. Penn State was a wonderful experience for me. The administrator there, Jan Williamson, was very supportive of my work, and even when times when I didn't want to do something, she would encourage me to go ahead and do it.
Her intellectual curiosity knows no boundary. If you would take a look at the books on Margaret's shelves, you can see the diversity of it, from books on architecture to physics to all kinds of different things, where she gets ideas. And then those ideas somehow are translated within herself and come out, in a sense, with some notion of health. And that's what's so stimulating about her. She brings that to a class so that a student isn't asked the normal questions you would ask in a nursing class. They're asked some very, very challenging kinds of things from a different field. And how would you use that from a nursing perspective? One of Margaret's major contributions has been to make people think. I think Margaret's theory and her ideas are those kind. They're not where you get your ahas today, but you may have an aha 5 or 10 years from now because of Margaret's work. And that, to me, is the lasting quality of it.
Dr. Newman discussed her theory of health as expanding consciousness with Dr. Jacqueline Fawcett on the campus of the University of Minnesota.
Margaret, I'd like to thank you so very much for agreeing to do this interview. I'm really interested in what you have to say today.
Thank you. I'm pleased to be here.
I'd like to start by asking you, what was your motivation for developing a nursing theory?
Well, that's an interesting question. You see, you don't really, or at least I didn't, set out to develop a nursing theory. Like, I didn't say when I grew up I wanted to be a nursing theorist. It's the kind of thing that you just kind of slide into. Throughout my doctoral study, I was interested in theory, and particularly the underlying theoretical rationale for hypothesis testing. I had become interested in the concepts of movement and time and space, which actually even went back to my earlier experience with my mother's illness, because I realized then, this was before I was in nursing, that her restriction of movement immobilized her in terms of time-space, and my relationship to that, my responsibility to that, did the same thing for me. So when I started studying rehab, the introduction to rehab actually used those concepts of movement, time, and space, and I became very much interested in them and wanted at that time to test specific relationships, say, between movement and time. And so throughout my experience in nursing, I was always asking questions and wanting to see the relationships, and specifically these relationships. So that even then, after I finished my dissertation, I moved into the concept of consciousness, and what really propelled the theory coming together was an invitation to speak at a conference on nursing theory in New York in 1978. And I had received that invitation back in '77 when I was teaching at NYU, and I was teaching a course on theory development. So when I received the invitation, I thought that's what they wanted me to talk about, this process of theory development. And as it got closer to the time for the conference and the directions from the people who were organizing the conference became more specific, it became evident to me that they wanted me to speak about my theory, which I didn't have at the time. But I had a lot of theory that didn't belong to me that I had been working with. And so I began to put together my ideas about temporal patterns of health and spatial patterns of health, and finally decided just to call this Toward a Theory of Health, because I didn't really have a theory, but I was getting there. And before I presented it, I thought, though, because I had been teaching doctoral students that they should identify their basic assumptions, that I had better identify my basic assumptions about health, since this was the main concept to be addressed. And I can remember sitting down at my kitchen table and saying, okay, what do I believe about health? And of course, the first thing that came up was the belief that disease is a meaningful aspect of health, because I had been through that with my mother, and I knew that simply having a disease doesn't make you unhealthy. And so then the other assumptions that emanated from Martha Rogers' assumptions about pattern and wholeness came forth too. And as I realized how important the basic assumption of pattern is, in terms of this assumption that disease is a meaningful aspect of health, you see, if pattern is basic and identifies the person, then the disease that manifests itself is a manifestation of that pattern. And that was a real revelation to me, that you really couldn't separate disease out and make it external or make it something that you fight against, because it's a manifestation of your pattern, and you have to get in touch with that. And so as I went down that list, I got to the end and I thought, well, now I've got to say more specifically what health is. And it just, all I can say is that it just came to me very suddenly, very quickly, that health is the expansion of consciousness. I owe a debt, I think, to Itzhak Bentov, who had written about the spectrum of consciousness and how consciousness evolves in the lifespan and through all of the levels of life, and even what we consider sometimes non-life, like the molecule level, that it is a process of expanding consciousness. But it all came together and it felt good. And then it became more a reality when I presented it at that conference in '78.
You've indicated that your mother's illness, Martha Rogers' conceptual system, and Bentov's work have all influenced your theory of health as expanded consciousness. What other influences have there been?
You mean theoretical influences, kind of?
Or personal experiences?
I think those are the main things in the beginning, those that you've mentioned. As I got into it more, David Bohm's theory of implicate-explicate order became very meaningful to me, because it seemed to explain what I was taking on faith, kind of, that that disease or any other manifestation of behavior, for that matter, is the explication, in Bohm's terms, of the implicate order, the implicate pattern that is there. And so I felt as though I felt strengthened by Bohm's work. And then, of course, along the same lines and about the same time, Prigoggine's theory of dissipative structures, because that theory explains the normal fluctuation to higher levels of organization.
Would you trace for us the development of your theory over time? What changes have occurred in your thinking?
I think I was very influenced in the beginning by trying to answer the demands of the logical positivist philosophy of science. And so I was intrigued with taking concepts as entities and relating them to each other in a specific way, propositional way, and then deriving hypotheses from that and testing those. And that was fun in the beginning. It was kind of like manipulating numbers or something. And I think it had it obviously had some meaning for me in being able to develop the idea of health as expanding consciousness, because as I looked at the time perception data from my early studies, in light of Bentoff's idea that time is an index of consciousness, there was evidence there that over the lifespan that there is this expansion of consciousness. Not conclusive evidence, but a hint there. And so I was involved in that way of thinking and that way of approaching this theory for quite a while, I guess probably through the early 80s even. And because I knew that that data wasn't conclusive, I felt like the next step was some kind of longitudinal study looking at the development of a person over time in terms of time as an index of consciousness. But at the same time, I was working with the the North American Nursing Diagnosis Association in terms of looking at pattern as the basis for nursing diagnosis, pattern of the whole, since we have made a commitment to looking at people as a whole and responding as a whole. And so pattern just became very, very important to me. And as I was trying to plan some kind of longitudinal study with these objective types of data, I also wanted some indication of the pattern of the person over time. And I had been using the work of Nanda with graduate students, and one graduate student brought some data in that we were trying to put into a pattern of the whole. And because the data for this particular client involved 3 different time periods, we had to sketch it, actually diagram it in a sense, at 3 different time periods. And all of a sudden it hit me that this business of expanding consciousness has to look at these sequential patterns over time. So my research assistant worked with me on developing some kind of interview protocol to get at this pattern. And one day she came in and said, I would just like to ask people what has been the most meaningful thing in their life. And I thought about it for a minute, and I thought, I could tell you what that is. And so we started using that. Actually, I was about that time working with Jim Vail and Richard Cowling on a pilot to develop some kind of methodology for pattern, and we used that question to start off the interview, and people are very sensitive to that and can tell you who have been the most meaningful people in their lives or what have been the most meaningful events in their lives. And overnight we put that into some sort of chronological order and could see the unfolding of this pattern over time, and of course in my view the unfolding of the consciousness. So that that emphasis on pattern identification and recognition became the center of my interest in terms of developing the theory and the research and the practice. And in a sense, they all came together because we could see through this process that the people we were interviewing were gaining insight in terms of their pattern. They were having ahas. And we, too, were having ahas, and we were being influenced by it. And so it was like practice. And at the same time, it was research.
How has your work influenced other people? For example, how has your theory of health as expanding consciousness influenced the way nurses think about health and about nursing?
What I hear from nurses when they call me is that it explicates their experience. It's not something that, it's not a theory that they go out to test or they go out to apply, but when they read about it, this is what they've been doing. This is an explication of what they have been doing, and or what they have been experiencing. Just recently, I spent 3 months with the nursing case managers at St. Mary's in Tucson, and my intent there was to learn what they were doing and to learn how it relates to the larger community of nursing within the hospital and in other agencies. And I learned that, but in the process, what I found out was that what they are doing is a good example of my theory. One of their primary things is to assist clients with their choices in difficult situations. And in my theory, I talk about coming to the choice point in life when the old ways don't work anymore. What used to be progress just doesn't work anymore. And all of a sudden, the person doesn't know which way to turn. And certainly illnesses and some of the difficult situations we deal with in nursing represent those difficult times when people don't know how to negotiate, so to speak. And so I have said that this is where nursing comes in, to assist the person in getting in touch with their pattern and making the difficult choices and moving beyond that to a higher dimension. And that's exactly what they're doing.
I wonder if you can tell us what you mean by consciousness. What is the essence of consciousness?
I'm defining consciousness in a way very similar to the way Bentoff defined it. He defined it as the quantity and quality of interaction with the environment. And I think I've added to that the informational capacity of the system. But this is Bentoff's idea too, in that if you look at some of the lower level systems, say a rock or an insect or a plant, the consciousness of that system, that is the ability of that system to interact with the environment, is the informational capacity of that system. Whatever information that system has is what that system uses to interact with the environment. So when you get up to the human level, I'm talking about the total information of the system. And that includes things like the immune system, all of the information of the physiological system, because that is part of our ability to interact with the environment. Very often people think when I use the term consciousness that I'm thinking of it in a cognitive sense or an affective sense. And those things are included because that's part of the information too, but I'm really talking about it in terms of the total. And I've changed that word quantity to diversity because quantity seems so linear also. It really means that it follows along the basic assumption from Rogers of increasing complexity.
Would you say then that your work traces back to Martha Rogers' conceptual system?
Oh, definitely, definitely. No question about it. I think the thing that stimulated me to try to explicate beyond what she has done is the lack of clarity about what health was. And she was always saying that health and illness are simply expressions of the life process, one no more important than the other. Well, that was very hard for me to understand in the beginning, and I kept hammering away at it, like, are they opposite ends of the spectrum? Are they opposite sides of the coin? And finally, I think through my study of biological rhythms, when I could see that the rhythm of a living system has peaks and troughs and periods of organization and disorganization, I could see health and illness as one phenomenon, one process moving through periods of organization and disorganization, or harmony and disharmony, and all of that being important. We'd hate to be on a straight line without those peaks and troughs. So I think that helped me to see it.
Would you tell us what you're doing now? What is the focus of your current work?
It's focusing on that pattern identification and recognition and development. When we started, after we developed this method of looking at pattern and seeing it as a very meaningful process for both the client and the researcher, I began to think of it more, well, first of all, I thought we should do this with a number of clients, and I wasn't sure who they should be, but since things like heart disease and cancer are major health problems, quote unquote, in our society, I thought to take a group of patients in these categories and look at them in terms of pattern would be meaningful in terms of my theory, because I've said that disease is a manifestation of pattern. So I've done this and am still looking at that data. I want to include in future studies the component that I see that is praxis, that is the expanding consciousness, and you can't really do that with well, you can interpret the pattern over time as being expanding consciousness, and I do, but I haven't really addressed the role of the nurse, the role of the nurse in this very clearly, except in terms of the mutuality of the interviewer and interviewee.
How would you explain the person who has Alzheimer's disease?
That is a frequent question. I had contact with a nurse in New Zealand who is very sensitive to other dimensions. And she was working with a patient with Alzheimer's, and so I asked her, I mean, she was familiar with my work, and she was working with patients with Alzheimer's, and I asked her this question, and she said, they've already moved into another dimension. And I tried that out on another nurse recently who works with Alzheimer's patients and whose mother-in-law died of Alzheimer's. And she said, oh, that fits. She said, they are not in that body necessarily. They have moved to another dimension, and occasionally they do come back. And that's what the nurse in New Zealand said. So we're evaluating them and their behavior from our level of consciousness, and these nurses who've had experience with this are saying that they are at a higher level of consciousness.
What are your plans for the future, your long-range plans?
I've been busy, I think, connecting up theory and research and practice in one, in a sense. And I did some work, I did some studies looking at the models of practice. This gets away from the theory a little bit, but the theory is not any good unless you have a place where you can practice it. And so many of our areas of practice are so restrictive and demanding in terms of time and the medical model and the bureaucratic needs and so forth, that I've been very interested in finding a way that nurses could really practice in the way that we are educated, in the way that we would like to practice. And so I've kind of had these other studies going on in a parallel way with the development of my theory as praxis. But it seems like now they're coming together, particularly with nurses who are able to function in an independent way beyond the walls of the hospital. They are able to direct their practice and be responsible for their practice. And so I guess I just want to continue to foster, support the nurse who is in practice, and foster graduate students who are to be able to develop their ideas in methodology that is consistent with our philosophy and basic assumptions in nursing, rather than meeting those external demands that we've done so much in nursing. I'm at a stage, I think, of being a mentor.
What has given you the most satisfaction in your career as a nurse?
I think probably my interaction with other nurses, whether they be students or nurses in practice. I love the process of negotiation, reciprocity, and empowerment. And I think that's it.
Margaret, I'd like to thank you again very, very much for agreeing to do the interview. It's been informative, fascinating, and it's been delightful to see you again.
Thank you, Jackie. It's been nice seeing you.
I think Margaret has brought freshness to the University of Minnesota because she asks new questions. She has a way of stepping back and looking at a bigger picture and asking questions that we hadn't asked. Margaret's a leader in a quiet way, not that she's quiet in terms of what her point of view is, because she's very articulate, but she doesn't make a lot of noise. She's certainly not a dominator. And I think she leads because she does what she recommends students do and what the rest of us do, and that is to come from the center of our own truth. And I think that's what I see her always doing. And if she's not doing it, she comes back and does that. And I think it's in her coming from the center of her own truth that enables her to be a leader. It's very clear that that's what she's doing. And in fact, it's that provides the leadership